Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm talking with Scott about physical therapy assessments and planning. Scott, if you would, please introduce yourself.
Sure. So my name is Scott Oliaro, and I'm the Associate Director of Sports Medicine at the University of North Carolina and their head athletic trainer. And I oversee our athletic training staff, and we work with the 28 sports at the University of North Carolina, as well as the student population, to try to keep our kids healthy, safe, and on the fields and courts. And when they get hurt, sick, injured, we do our best to get them back safely, healthy, and as quickly as we possibly can.
Thank you, Scott. And the first question is, I have a team guy who's been injured, is recovering from, whatever kind of injuries, like shrapnel or a gunshot wound or something like that. And I need to get him back to being on the team fully functional. So I think it'd be very similar to maybe a football player or something who has broken his leg or broken an arm or something like that.
Yep.
Okay.
Yeah.
How do we get him back to function, while we're deployed? How about that?
Yeah, I think the number one thing that you mentioned is just making sure that wounds are clean. Mm-hmm. We don't get infection, and then progressing exercise based on what you see. And I think a lot of it is the evaluation of what are the restrictions, and depending where shrapnel and wounds are, you're looking at whether it affects ankle, knee, joint, hip, all the way through, depending obviously where the area of the wound is. But assessing those restrictions and then coming up with a plan to work on those, whether those restrictions are movement, mobility, whether it's a strength issue, whether it's a functional issue, or all of it. Mm-hmm. I think the basis of this is being able to move the appropriate joint, use the appropriate muscles to develop the movement patterns that are necessary, and then adding the appropriate stress to those muscles and strengthen those muscles to allow them to do the necessary movements to return them to the skills that they're used to doing. So shrapnel in the leg, wound healing in the leg lower quarter, looking at being able to move the ankle, being able to move the knee, the hip, getting the whole lower extremity involved in the return process, making sure that the movement process is fluid, the strength is developed, and making sure that the patient's ability to handle the load and the stress of each step as you progress. So it can be something like just doing ankle range of motion, doing knee range of motion, doing quad and hip strength, to then loading it with just standing, bilateral, then standing unilateral, one leg, walking with assistance, whether it be crutches or another assisted device, and then walking on their own, and then progressing that to returning them to a higher level of function with more functional movement, with marching, skipping, jogging, running, and then looking at what they need to do to get back out into the field.
Okay. Could maybe you just walk me through how this assessment would go? Say you have a soldier in front of you, and he's He's gone through, whatever medical treatments need to be done, and he's definitely on the recovery process. How would you go through assessment and in order to set up some kind of a program, I guess, for him?
Yeah, I think the first couple of things is looking at an overall movement screen, an overall movement assessment, to see where restrictions are and see where limitations are, and whether that's ankle, hip, knee, core, wherever that may be, to see what are the areas that are of concern, what are the areas that are limiting that soldier before they go on to do any type of real stressful physical activity. And then looking at some of the basic things that soldiers need to do and testing them on those things, and whether that is a timed run, whether it's a series of calisthenics, but evaluating the ability to move with those tests, as well as the measures of those tests, and seeing where those fit in to where the rest of his team is, to the rest of his group is, and being able to come up with an assessment of what percentage he may be at compared to the others, and then developing those programs that are based on his restrictions and based on his shortcomings to return. And nobody likes to really work on their weaknesses. They want to continue to do things to do well. But if somebody is lacking lower extremity strength, but they can do 1,000 push-ups, they'll still want to do 1,000 push-ups. So you got to look at what is restricting them in their return to participation and work on those areas. So then they're equal or better than their teammates as they move into doing those things with them.
So when you say restrictions, are you talking about pain or like physical limitations to the range of motion?
Well, I think pain is a limiting factor in a lot of things. So if you can reduce some pain, you may be able to get more out of the activity. But I think noting what the restrictions are, because it can be all of the above. You could have restrictions from pain, or you could have painless movement, but it's still restricted because there's either a soft tissue block or there's a mechanical restriction that's in place for one reason or another. Maybe it's scar tissue. Maybe there's just something that's it's been tight because it hasn't been used in a long time. Maybe it was there before, and now we're just recognizing it because the person has been injured, and now we're noticing that, hey, this is going to be something that's inhibiting you as well. So whatever is in the way of that person returning, so whatever restriction it may be, you need to address it. And certainly you're not going to be able to possibly tease out everything. There's things that certainly 100% healthy people are restricted with. But if those restrictions are resulting in decreased performance, deficits in strength, deficits in motion or function, then they need to be addressed.
Okay, so essentially, it sounds like to me, I'm essentially doing like a musculoskeletal exam, figuring out where their ranges of motions are, their muscle strength, things like that, sensory, and then I'm assessing them on different activities for whatever they were doing for an occupation. So as a soldier, marching, running, carrying weight, things like that, until I find what they can do and what they cannot do, right? And then,
correct. And then you have to do a progression, right? So it's not like you have the soldier that's returned, good range of motion, the strength is there, they're walking well, and then you say, okay, great, you're ready to return. And you've got to build up their stamina, you got to build up their endurance, you got to build up their muscle endurance, you got to increase their load. Otherwise, you just set them up to fail, whether that's stress reaction, stress fracture, or just limiting their ability. So you've got to look and develop a return to combat or a return to training program for that individual. So they don't start with, all right, well, looks like you're walking okay, you're not in pain. The platoon has to run 5 miles today. Let's see how you do. Right? There's a better way to address those things.
Okay. So I guess how would you do it?
Well, again, you look at goals and timing, and let's say somebody has to do a 5 mile run, and they just started back, and part of this is how long have they been out, right? So if they've been out for an extended period of time, it's going to take a little bit longer to get back to that goal. But it's a matter of starting at a point where you can do some loading and activity, and then adjusting as they adapt. So, for instance, if we have to do 5 miles, maybe we start at 2 miles, and what we'll have them do is jog for 1 mile, jog for 1 minute, walk for 3. Find a ratio that they're comfortable with, and see how they do with 2 miles, and then we adjust variables singly, meaning that we wouldn't increase the pace and increase the distance on the same day. We would negotiate one of those two and change them over a percentage of increase maybe the distance by 10 to 20% each week, and eventually get there. We can certainly accelerate that if things are really easy, or we can back that off depending on how the person reacts. But I think the important thing is to have a plan that is adjustable, and it's based on how the athlete or how the soldier or how the person is responding to it with a specific timetable of expectation.
Okay. And with that, do you, again, using pain, or I guess...
I think you use pain as part of it. You also use some objective measures. Are they swelling?
Okay.
Do we see a more restriction after they're done? Are they limping? Is their gait changing? If they do the walk, jog, march one day, are they extremely sore the next and unable to do it? So there's a lot of factors that go into making the decision of what to do the next day or what to do in the next workout. But all those things factor into the plan, and it's an adjustable one. It's not going to go linearly and exponentially. It's going to be a little bit of a sine wave.
Right.
It's going to go up and down a little bit, but it's progressing. If you look at the overall scatter plot of that, it should be going upward continuously.
Right. How soon after injury do you start getting guys up and moving?
I think it depends on the injury, but we try to do it the next day.
Okay.
I think the sooner people recognize that yes, this one joint, or if it's multiple joints, whatever is hurting them, but the rest of their body is okay. Athletes tend to want to do something about it, right?
Right.
So whether or not that's increasing their fitness level, or maintaining a fitness level, or increasing blood flow, or doing, like somebody that tears their ACL, we're trying to get them to pump their quad and fire their quad, get their muscles working almost immediately, so we don't delay healing, we don't atrophy the leg, and we start the return process as soon as we possibly can.
All right. So essentially, as soon as it's medically safe for them to move around, you get them up and start doing something.
Yep, and we like to do that. And again, if somebody, when they're safe and when it's okay, if it's a lower extremity injury, we can work upper body. We can work on a lot of other parts, the opposite leg, the opposite limb, their core strength. There's options for cardiac training. that are both upper and lower extremity. So we want to continue to engage them in a process.
Okay. I guess, setbacks always happen, right? Especially with athletes, and I'm sure, soldiers are exactly the same way. They're going to push themselves until they break. And it's not going to be any different during the healing process. How do you deal with setbacks?
Well, I think the understanding and the education of what caused the setback and where we are now in the plan is important to have that communication with the athlete to say, okay, hey, we've taken a step back, but here's what we need to do going forward, and let's learn from this and create new short-term goals and still continue with the long-term goal, but have some idea of what it's going to take now to get back to where you were. Let's say from once you've taken that step backward or 2 steps backward, to say, how do we go forward and how do we get over this hump, or how do we change this? And I think of patellar tendon inflammation and irritation with a knee that's been operated on surgically, and having a setback from the anterior knee pain, saying, okay, here's how we're going to address this, and then going forward, we're going to concentrate more on these 2 exercises to get us over the hump so that anterior knee pain doesn't happen, and then we can move and advance forward rather than trying to repeat the same thing and getting the same outcome.
Mm-hmm. Outstanding. What guidelines are there out there for as far as physical therapy and evidence-based practice, as far as setting up programs and different exercises and things like that?
Well, a lot of it's based in working with the surgeons. If it's a surgical issue, to say, okay, a hip labral tear, an ACL tear, ankle reconstruction, whatever it is working with the surgeon to say, how much immobilization do we need? How much, can we bear weight immediately? How much time off non-weight bearing do we need to have for those tissues to heal? And then stressing those tissues in a specific way so that you stress them, but you don't damage them. Mm-hmm. And there's, depending on what injury it is, there are research and there are best practices and there are protocols in place to base things off not only on timing, but on specific exercise. And I think as things have progressed in the last 10 years or so, people have gotten pretty specific about how they want their patients to negotiate the therapy following specific surgeries, and whether or not that's a hip and doing a lot of pendulum and passive range of motion, or it's an ACL and we're doing a lot of soft tissue and quad control and patella mobs, and really not letting that leg atrophy. Each injury would have a specific protocol or guideline to utilize that's based on the best evidence practice. But you have to vary with that based on what you see with the athlete. Mm-hmm. And some will be able to accelerate a little bit, and some will have those roadblocks and bumps in the road that you need to negotiate and work through and work around. So yeah, it's important that the athlete or the soldier understands that while this is the guideline, this is the protocol, every injury is different and everyone is going to react differently, and we're just going to use this as a guide, but the signs and symptoms that they show will determine the process and the procedure.
Right. Are there any societies or associations that you use for your practice?
We use a lot of guidelines from the NATA in terms of just regular best practice protocols. We also, again, just work with our surgeons, and then work with our group to look and establish kind of a best practices, some peer-reviewed journals that look at what's Journal of Orthopedics is a good one that looks at outcomes, and we're reviewing a lot of different things to kind of put our best practices together. Mm-hmm. And we usually review those on an annual basis and say, okay, what else is out there now that's showing that this is a better way to do this. But most of these things are dependent on the surgeon and their comfort with the protocol and the guideline, and certainly with their own operation and procedure.
Oh, great. Yeah. The reason I wanted to talk to you is, having been downrange myself several times, but guys obviously get injured. American soldiers, they can be evacuated and receive the care that they deserve. But either they will come, if they do come back, they will have some kind of physical therapy that they're going to need to continue to some extent, or like the local nationals that are working with us, they're really not getting evacuated. So somebody like myself will have to continue that care and come up with the plans and et cetera, to actually get them back to some level of function anyway.
Yeah.
If not back to the fight where they started. So I'm just wondering. I've done lots of podcasts on resuscitation and pain and airway and all those things. I've done podcasts on the surgery part of it, but it's in nutrition, but not the actual, like, all right, this is how you get the guy up and out of bed and get him walking again. And, these are the kind of goals that and assessments that you're going to do.
Well, and that's, again, that's a big part of what we try to do is convince them that they're okay, right?
Right.
and having the little victories, and that's why those daily goals are so important, and having them understand what's been done to them, what's happened to them, why they're injured, what part is injured, what part still works, what part we can stress. Mm-hmm. Having them communicate to us. And one of the things we tell them is, this is their injury. We're going to help them with their injury, but they've got to own this.
Right.
And it helps them to kind of say, yeah, this is what I need to do. And as we progress them, we tell them, like, you might spend an hour and a half, 2.5 hours with us, but there's another 22 hours during the day that you need to work on this.
Right.
And this is still something that is yours, and we're going to help you with your injury. And I think that's the people that accept that tend to do a lot better mm-hmm. than the people that don't.
Right.
And it's a mindset change for them too, because a lot of people that haven't been hurt before, this is foreign to them. Oh, and having to add one more thing onto their plate, and something that's for athletes and Sam's on the shoulders, when the thing that they want to do is taken away from them, it's really hard.
Yeah.
And so having them be able to focus on, this is what we need to do to return. This is a process. And like I said, outlining it from their ultimate goal and working backward to say, in order to do this, these are all the things that need to go into place. And then for them to understand why we're at the process we are, and what the goals are for that session or that week, so that we can hit those things and have some success and have some victories, and give them something to look forward to, and give them something to attain, because they're usually pretty goal-oriented people.
Right.
And when you take their sport away, there's got to be something they can compete with, right?
Right.
So doing those things is helpful.
Oh yeah, And I imagine up front you have fairly, small victories, like, taking care of yourself or walking, whatever distance. I think I would imagine having small victories early kind of begets big victories later on.
Yeah, absolutely. Being able to tighten your quad, make your patella move, and lift your leg up. It doesn't sound like a big deal, but for someone that just had ACL surgery, that's a huge thing.
Right.
And that begets allows the next step to take place. But if those things don't work well in the beginning, it's a long road, and it makes the next step much more difficult.
Is there anything that you think would be really important that we haven't gone over?
I think one of the things maybe that is important is that every athlete, every soldier, every injury is a little bit different, and so you've got to treat them all individually. And while you have protocols and guidelines, the communication and the trust between the athletic trainer, therapist, and the patient has got to be there for it to work really well, and to be able to communicate openly, honestly, and directly about what needs to be done, about what expectations are from both ends, I think creates a successful environment where each can trust each other and know that the best interest is foremost in their mind, and that they're going to go through this journey together, and trusting the process that the therapist, the athletic trainer, has been through, and explaining how this is, having them be involved in the process is a big factor in their success as well. They can't be a passive participant in this.
Yeah, absolutely. Hey, well, thank you, Scott.
Yeah, you're welcome. I'm glad we could finally do this.
Yeah.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.